So that was it for microcytic anemias. Now we move on to normocytic anemias. And how do we define or categorize normocytic anemias? What was the MCV that we said? Remember, we said the MCV was between 80 to 100. So if they tell you MCV is 80 to 100, it's a normocytic anemia, and the etiology is probably going to be one of the following that I'm going to talk about. First, we can divide normocytic anemia even more. We can divide it into hemolytic versus non-hemolytic causes. So hemolytic means that you have destruction of red blood cells, and so you're going to get increased reticulocytes. I'm going to tell you what those are, but these are basically red blood cell precursors. So if you're destroying red blood cells, you want to make more, you're going to get more precursors, you get more reticulocytes, you get more than 2% reticulocytes. Because usually the normal amount of precursors is around 1 to 2% of the total blood volume. In a non-hemolytic cause, the problem is you're not able to produce red blood cells. So your bone marrow is not working, you're not making red blood cells, and so you have anemia, and it's normocytic, but it's non-hemolytic. So if your bone marrow is not making red blood cells, what happens to your reticulocyte count? Well, your reticulocyte count then is low, so it's less than 2%. So now we can even further divide even more. We can take our hemolytic anemias and we can divide them into the reasons why there's hemolysis. There's an intrinsic causes of hemolysis and there's extrinsic causes. So intrinsic means there's something intrinsic to that red blood cell. There's something inherently wrong with that red blood cell that leads to its hemolysis. And the extrinsic problem means there's something outside, extrinsic to the red blood cell. There's nothing wrong with the red blood cell itself. There's something wrong with the body or in the blood that's messing up the red blood cells and causing hemolysis. So again, big picture, we're looking at normocytic anemias now, MCVs between 80 to 100. Now we can divide the normocytic by etiologies. We can look at whether there's hemolysis of red blood cells or whether there's not hemolysis. And if there's hemolysis, we can look at whether the hemolysis is inherently due to a problem in the red blood cell or a problem outside of the red blood cell. Now I want to complicate it even more, and we're still going to look at hemolytic anemia, but we're going to say there's even more. We can classify it another way. We can classify it by the intrinsic versus extrinsic causes, or we can classify whether the hemolysis occurs intravascularly or extravascularly. And the reason why we do that is this difference can, well, there's going to be slight changes in the labs that you're going to see. So if it's intravascularly, that means there's hemolysis happening in the blood vessels. And if this happening in the blood vessels, you get hemolysis, you get hemoglobin coming out of the cells, and then the hemoglobin leaks out into the blood. And what it's going to do, it's going to bind to haptoglobin. So hemoglobin binds to haptoglobin. So what you're going to see is you're going to see increased serum and urine hemoglobin. Because again, there's hemolysis in the blood vessels and it comes out. So it comes out into the serum, it comes out and then eventually goes to the urine. And then because we're binding to haptoglobin, you're going to bind to it so there's less free haptoglobin. So there's decreased haptoglobin. That can be something that's a little tricky. In hemolysis, we have decreased haptoglobin because the hemoglobin binds to it. Now, there's a couple of other things you're going to see. You're going to see hemosiderin, hemosideриnuria. So there's hemosiderin in the urine. That's from breakdown of iron in the hemoglobin. And pretty much like every other cause of cell breakdown, you're going to see increased LDH. So increased LDH in hemolysis. Because LDH is found in almost every cell of the body and it's released with cell damage or death, which is what's happening with this hemolysis. The last thing you can see is you can have some unconjugated bilirubin that's from breakdown of protoporphyrin. So next is extravascular hemolysis. Let's clear our drawings. So extravascular means it's not in the vessels. So where it happens is it happens in the spleen, the liver, and the lymph nodes. We call it the reticuloendothelial system. We call it that because there's these macrophages here. So macrophages in the spleen, the liver, and the lymph nodes will destroy the red blood cells. Then they're going to end up breaking the red blood cells down into its constituent parts. So they're going to break down. So what are the constituent parts of the red blood cell? Remember, red blood cell has a bunch of hemoglobin. We can break that down. Let's break down the hemoglobin. So you can break down it into heme and globin, right? So heme is globin. Globin is just a protein, so it's a bunch of, you can break it down into amino acids. And then the heme, what do we say was made up the heme? Remember, you get iron, you get porphyrins. Struggling how to spell it. But so iron and porphyrins. And then finally, what can we break porphyrins down into? Remember, porphyrins we can break down into bilirubin, into unconjugated bilirubin. So you get a lot of iron, you get unconjugated bilirubins, you get amino acids. And this bilirubin can go around and cause problems. It can go deposit into the skin, and you can get jaundice, and you also can have bilirubin gallstones. So that can be problems from extravascular hemolysis. And the reason why you would get extravascular hemolysis is there's some abnormality in the structure of the red blood cell, and that's going to cause the macrophages to sense that. They're going to sense these abnormalities in the red blood cell. They're going to sense it, and they're going to break it down and destroy those red blood cells. So examples of this include hereditary spherocytosis. I'm going to talk about all of these later, so don't worry about it. You don't have to memorize it now. And then the sickle cell anemias, sickle cell and hemoglobin C, which is pretty much a minor variant of sickle cell. So intravascular happens, and you get hemoglobin leaking out into the blood vessels. And hemoglobin, you're going to see hemoglobin in the labs. You're going to see increased hemoglobin in serum and in the urine. And what was the other thing? What happens to haptoglobin? Remember, haptoglobin is decreased because it binds to hemoglobin. And you see other labs like LDH and hemosideruria. And you're not going to see that stuff in extravascular hemolysis because you're going to get breakdown of the red blood cells, and they're going to get digested by the macrophages. And instead, what you're going to see is the macrophages are going to break down the hemoglobin, and eventually you're going to get the porphyrins, and the porphyrins are going to break down to unconjugated bilirubin, and that's how you can get problems in extravascular hemolysis. And then just to bring it back, we said, again, normocytic, break it down into hemolytic versus non-hemolytic. And then we talked about hemolytic a lot. We talked about how we can classify it into intrinsic versus extrinsic, but now we also talked about how we can also classify it, whether it's intravascular or extravascular. Now, when I talk about normocytic, let's go to reticulocytes first. I want to introduce that first. And we said that reticulocytes help us differentiate whether the normocytic anemia is a hemolytic cause or a non-hemolytic cause. So reticulocytes, I told you, they're newly formed, they're relatively immature red blood cells that are released by the bone marrows into the blood. So these reticulocytes are going to circulate for about a day in the blood before they eventually develop into mature red blood cells. So normally reticulocytes make about 1 to 2% of all red blood cells. That's a normal amount. That's when your bone marrow is making a normal amount of red blood cells, because even now your red blood cells are flowing around, and you're going to lose some red blood cells. They're going to die, and you're going to need to replace them, and you're replacing them with 1 to 2% of reticulocytes. Now we can use this reticulocyte count as a marker of bone marrow activity. This is the reticulocyte count. So in a hemolytic anemia, what's going to happen to your reticulocyte count? You're losing a lot of red blood cells. Your bone marrow wants to replenish it, so it's going to have increased activity. You're going to have increased reticulocyte count. So you can say even like a 3% reticulocyte is going to be increased reticulocyte count. Now in a non-hemolytic anemia, what's the problem? Remember, the problem is that your bone marrow is having trouble making red blood cells, so it's not making the precursors either, so your reticulocyte count is decreased. So that's a very easy way to differentiate hemolytic versus non-hemolytic anemias. Now let's go into hemolytic anemias we talked about, and we're gonna classify it based on intrinsic versus extrinsic causes. That just helps you understand the pathophysiology a little more. And we're gonna look at the intrinsic causes. We said intrinsic causes. What did we say? It was an inherent problem with the red blood cell. Okay. So there's going to be a few we're going to talk about. The first one is going to be paroxysmal nocturnal hemoglobinuria. Let me break that word down a little bit. Paroxysmal just means it comes once in a while. It's not every time, but once in a while at night. So some nights you get hemoglobinuria. So hemoglobin in your urine. And hemoglobin makes your urine darker. So the whole problem here is there's a defective GPI anchor on the red blood cell. So on a normal red blood cell, there's a GPI anchor. And in this one, there's defective. But the reason why we care about the GPI anchor is that is needed to secure DAF. DAF stands for decay accelerating factor. So you need that GPI to secure DAF. And the reason why you want DAF is DAF helps protect against complement. Okay? It helps the breakdown of complement, so it causes decay of complement. So if you don't have this, if you don't have GPI, no GPI means no DAF, because there's nothing to anchor the DAF. Now complement's going to come, and nothing's going to, Nothing's going to immobilize, Just turn it off, nothing's going to turn on complement. Complement's going to come and damage the red blood cells. So you're going to get red blood cell damage from complement due to lack of this GPI anchor and the lack of DAF. So damage to red blood cells leads to intravascular hemolysis and anemia. And the clinical features here you're going to see are going to be a triad of anemia due to hemolysis. You're going to get venous thrombosis, and you're going to get pancytopenia. So the venous thrombosis is because of release of prothrombotic factors from your lysed red blood cells and platelets. And then pancytopenia is just these patients are at risk for bone marrow insufficiency for some reason. And how can pancytopenia present? First of all, what is pancytopenia? It's some fancy word. It means your bone marrow is just struggling to make anything. Remember, bone marrow makes white blood cells, makes red blood cells, makes platelets. So what's going to happen if you have pancytopenia with low levels of all of these? White blood cells, you're more susceptible to infection. Okay, and then platelets, what happens? Spelled that wrong. Infection, it's called X. Platelets, what happens if you're missing platelets? You're going to be more susceptible to bleeding. So these patients can bleed, and the red blood cells, you get anemia symptoms. The other thing you can see is you can see intermittent jaundice and episodes of red or dark urine. So that's where the name comes from, I told you. So back in the day, you'd see these patients who have this disease, they wake up in the morning and they have really dark urine, red dark urine. So you would think they have hemoglobinuria, you think it's like a nocturnal cause. But the real reason why it happened in the morning is, if you ever peed in the morning, if you pee in the morning, you know that your urine's usually darker than usual. It's because you haven't peed the whole night, so urine's extra concentrated. And so for these people, their urine was extra concentrated, it was high in hemoglobin, and then so that's why the urine looked darker, looked red, and it looked like hemoglobinuria, which it was. So this is a misnomer. These guys have hemolysis at a steady rate throughout the day. It's not paroxysmal, it's not nocturnal, it's steady rate throughout the day. So for labs, what are we going to see? What we do is we test for the presence of GPI and DAF. Okay, you do flow cytometry, you look for CD55 or 59, and that's basically just DAF. So you look for DAF on flow cytometry, and obviously these guys are not going to have DAF, so they're going to be DAF CD55, 59 negative red blood cells. Now when you treat this is you give them eculizumab, and this inhibits complement formation, because remember that's the problem here. No GPI, no DAF, too much complement action on red blood cells and hemolysis. So you give them eculizumab. So that's it for paroxysmal nocturnal hemoglobinuria. Next is G6PD deficiency. So this is a X-linked recessive defect in the G6PD enzyme. And what this leads to is it leads to reduced glutathione. And this is the biochemical reaction that causes that. So G6PD you need, basically it helps you get NADPH, and you need NADPH. It's in the co-reaction to reduce glutathione. And the reason why you want reduced glutathione is it helps get rid of your all these oxidative factors. You don't want these oxidative factors. They're going to cause a lot of damage. So reduced glutathione helps neutralize this H2O2 into water. But when you reduce it, it becomes into the oxidized state. So you need to reactivate it, you need to reload it. And to reload it, you need this. So to get this, you need G6PD. So G6PD, you basically need to reload your reduced glutathione. Now, the things that can cause problems here, because if you don't have enough of this, you get too much oxidative damage to the red blood cells. This is especially a problem when you intake stuff that gives you increased oxidative stress. So for example, things like sulfa drugs, antimalarials, fava beans, and infections. All of these cause increased oxidative stress in your body. You get too much H2O2, you have not enough G6PD, so you're going to get increased oxidative stress on the red blood cells. You're going to get hemolysis, you're going to get too much hemolysis, and you're going to get the following symptoms. But again, I want to reiterate, just so you want to memorize this, you want to be able to recognize this. The stuff that triggers this for G6PD patients, the G6PD deficient patients, are sulfa drugs, antimalarials, fava beans, and infections. Again, you want to memorize that. So clinical features, you're going to get hemolytic crises, so occurring after a trigger. And again, you often see this in African patients, Asian patients, and Mediterranean people. What you're going to see, you're going to get sudden onset back or abdominal pain plus the hemolysis symptoms. So you get jaundice and dark urine. So sudden onset back or abdominal pain with some jaundice or dark urine. And you often see this, you might hear in the history that they had some trigger, like they started taking drugs for a skin infection, or they had malaria and start taking drugs, or they start eating fava beans, and then they get, again, what were the symptoms we said? Sudden onset back or abdominal pain, jaundice, and dark urine. And for labs, what you're going to see is you're going to see Heinz bodies and bite cells, and this is very characteristic. So a Heinz body is this stuff. This is precipitated hemoglobin. It's due to oxidative stress. You get precipitation. And what's going to happen is your macrophages, these cells are going to go to the liver. Macrophages are going to see these Heinz bodies. They're going to say, that's abnormal, that's not right. And they're going to take a nice fat bite out of it. You're going to be left with bite cells. So that's why you have Heinz bodies and bite cells in G6PD deficiency. Next is pyruvate kinase deficiency. This is, you can tell from the name already, autosomal recessive defect in pyruvate kinase. And the thing is that glucose is the only source of energy for red blood cells. And you need pyruvate kinase to be able to break down glucose into ATP. So if you don't have pyruvate kinase, red blood cells can't use that glucose, so they have no energy. So they have shortage of ATP. They've built up of molecules that was in the glycolysis process that is breaking down the glucose. And so you're going to get buildup of all this stuff and shortage of ATP. You get extravascular clearing of abnormal red blood cells. So that's how you get problems in pyruvate kinase deficiency. Finally, our last one that we're going to talk about is hereditary spherocytosis, an autosomal dominant defect in proteins needed to tether the red blood cell cytoskeleton to its membrane. So most commonly, the proteins that are defective are ankyrin, band 3, or spectrin. You also want to memorize these. Ankyrin, band 3, or spectrin. So your red blood cells have a nice little cytoskeleton that helps, and then nice membrane here. Normally it's tethered, so you get a little bit of structure for the membrane. If you have defects in this, what were the three things? Ankyrin, band 3, spectrin. Then, first of all, you have very fragile red blood cells. And also want to mention, because these are unable to tether, what you're going to get is this cytoskeleton, and your membrane can bleb out because it's not stuck to the cytoskeleton anymore. You can get blebs, and what's going to happen is your membranes are going to shear off. There's going to be shear stress. They're going to get ripped off. You're going to lose membrane. First of all, you're going to lose surface area and volume, and you're going to get smoother red blood cells. They're going to become more sphere-like, in a small sphere shape, and that's why we call it a spherocytosis. So again, these red blood cells, these spherocytes, are more fragile. They're super fragile, and they're unable to change form while going through narrowed vessels. So that's why when they're going through the small vessels of the spleen, they get stuck because they just can't change form and squeeze through. So they get stuck, and they end up being removed by splenic macrophages. Because remember, there's something structurally wrong with these red blood cells. The macrophages recognize that, and these guys are just sitting ducks. They're just stuck in the splenic microvessels. So the symptoms you get symptoms from elevated unconjugated bilirubin from extravascular hemolysis. So I already mentioned some stuff you might get. So you might get, remember that bilirubin deposits in the skin. You get jaundice, so yellowing of the skin. You also get bilirubin gallstones. The other thing is you're going to get spherocytes with loss of central pallor and smaller size. And you get this increased MCHC. This is basically it just means hemoglobin concentration. So you're going to get increased hemoglobin concentration because you have the same amount of hemoglobin and you have the small size. So again, this is a spherocyte. It's very sphere-like. There's a loss of central pallor. You see, normally there's central pallor here. There's no central pallor here. And so that's a spherocyte. Finally, you're going to get splenomegaly. Why are you going to get splenomegaly? Because you have all these red blood cells, all these spherocytes that are stuck in the vessels of the spleen, and they just end up getting trapped there. And so they're going to build up, and they're going to cause swelling of the spleen, and you're going to be enlarged. And finally, the way we diagnose this is with the osmotic fragility test. So there's increased fragility here. I told you this is the key word here, increased fragility. So you get, again, just to recap, increased fragility. They get stuck in the vessels of the spleen. You get hemolysis, extravascular, so you get all that bilirubin. So you get symptoms from bilirubin, jaundice, gallstones. You have this classic spherocyte appearance. You get splenomegaly, they're getting stuck in the spleen. And then the lab test is easy. It's osmotic fragility test. And then the defect in the protein, what did I tell you was the defect in the protein? It's ankyrin, band 3, and spectrin proteins. So that's it for our, well, this is part 1 of the intrinsic hemolytic anemias. So the next video will also continue with the intrinsic hemolytic anemias. So intrinsic, hemolytic, these are normocytic anemias. Alright, so that's it. Actually, just what were the 4 that we talked about? We talked about hereditary spherocytosis. We talked about pyruvate kinase deficiency. Remember that red blood cells need pyruvate to break down glucose, which is their only source of energy. And then we talked about G6PD deficiency, which is needed to help act as an antioxidant, help get more antioxidant to neutralize H2O2, and it's precipitated by a couple things. Remember what I told you precipitates G6PD deficiency attacks. Remember I told you sulfa drugs, antimalarials, fava beans, infections. You get these Heinz bodies and bite cells. Heinz bodies and bite cells, you know, G6PD deficiency. And then paroxysmal nocturnal hemoglobinuria. What did I tell you was the defect there? I'm sorry, I'm all over the place here. What was the defect in paroxysmal nocturnal hemoglobinuria? Remember, it's missing GPI anchor, so you don't get enough DAF. So you don't have DAF, so you have overactive complement leading to destruction. And then you have that triad: anemia, venous thrombosis, pancytopenia, and that's it. So that's our review of part 1 of the intrinsic hemolytic anemias.